Okay, so this is going to be the Chapter 7 and 8 or Module 1 exam review. I have a little slideshow that I'm just going to have up there just to kind of give you something to look at other than me. But I'm going to go through the book and tell y'all some important things y'all need to know and the things y'all need to focus on. I'm going to explain some concepts. And I'm going to tell y'all there's some things in here that are nice to know and you don't really need to study that much. Okay. In a little while, I'm going to draw something on the whiteboard. Hopefully I can turn this laptop around and show y'all. And I hope it all works out. All right. Okay, so the first thing we need to talk about is anatomical terms, all right? Some terms that y'all need to know are supine and prone. I'm not going to go over those, but those are simple terms that y'all can learn just by reading the definition. Lateral recumbent, Fowler's position, semi-Fowler's position, Trendelenburg, shock position. Those are all things that you need to know. Okay, so on this slide, it talks about anatomical planes. All right, so y'all need to know the different anatomical planes and definitions such as anterior, posterior, superior, inferior, dorsal and ventral, medial and lateral. Okay, now let's stop and talk about medial and lateral because a lot of people kind of get those mixed up. When you talk about the body, when you're looking at the body and you're talking about something that is medial, it's towards the midline, okay? So if I hold my arm up, okay, like this, medial would be towards my body. Lateral would be away, okay? So that is medial and lateral. When you hear the term bilateral, that just means both sides. Proximal and distal. These are two common terms that people have a hard time grasping sometimes. Proximal, when they talk about proximal and distal, they're talking about insertion points and they're talking about the extremities, arms and legs, okay? So the insertion point is either the shoulder or the hip, okay? Proximal means moving towards the insertion point. Distal means moving away. So if I hold my arm out, okay, usually there's a reference point that they're talking about, and you have to know if something's either distal to it or proximal to it. So an example would be let me turn a little bit. So if I have a wound right here on my arm, okay, it is distal from my elbow because I am moving away, all right? The wound is away from this point in particular I'm talking about. So the wound is here, it's distal to my elbow. Now, or I could say it's proximal to the wrist because it's above the wrist, okay? And it doesn't matter which way the arm is held. Distal is moving towards the fingertips. And same thing for the legs, all right? My wrist is distal to my elbow, right? So if we want to reverse that, my elbow is proximal to my wrist, okay? This is proximal to the wrist. There's some terms, mid-clavicular, so your clavicle, it's just an imaginary line straight down, mid-clavicle, straight down. Mid-axillary is basically the middle of the armpit, straight down. You need to know the different abdominal quadrants. You have the right upper quadrant, left upper quadrant, right lower, and left lower. And a lot of times these are abbreviated. So you'll see RUQ, RLQ, and so on. Just when you see those, you know what they're referring to. The musculoskeletal system, know the definition of a ligament and a tendon. Once again, I'm not going to explain that just because it's a simple term that you can read. Okay. Parts of the skull you need to know. Once again, it's pretty self-explanatory. It's in bold in your books. Okay. You need to know what the maxilla, the mandible, zygomatic bones. You need to know what those terms are. The spinal column, right? You need to know each section of the spinal column and how many vertebrae are in each. So you have the cervical, thoracic, the lumbar, sacral, and coccyx. So you need to know how many vertebrae are in each one. The thorax, when it refers to the sternum, know that the sternum is made up of two parts, actually three parts. You have the body, the main part, the upper part's called the manubrium, and the lower part, that little tab, is your xiphoid process. Then moving on down, the pelvis, you need to know the pubis and ischium, those definitions, and the lower extremities. You need to know all the bold print words, okay? The femur, patella, tibia, fibula. Y'all need to know where all those are located. Also in the upper arms, you need to know the major bones, the humerus, the radius, the ulna. Then we're going to talk about different movements or motions, okay? So we're going to talk about flexion and extension, okay? Flexion and extension. So when you flex, you're thinking of flexion muscle, so you move it towards the body. Extension naturally would be away. So flex and extend. Now there's two more terms that mean the same thing, abduction and adduction. Think of adduction, ADD, as adding it to the body. So it's the same as flexion. Abduction is the same as extension. So y'all need to know those terms. Now, it talks about the different joints of the body, and it talks about all the different locations like ball and socket, hinge joint. That's nice to know. Don't spend a lot of time studying that, okay? Moving on, skeletal system, you need to know the skeletal muscle, and you need to know smooth muscle, cardiac muscle, voluntary muscle. So know the definitions of those. You will not have to identify it by sight on a slide, okay? You just need to know the definitions of those. All right, respiration. Respiration and ventilation. In the technical sense, respiration occurs at the cellular level, okay? That means we're moving oxygen and carbon dioxide in and out of the body, right? To the cells. Ventilation is the physical movement of air in and out, all right? When you ventilate someone, you're physically moving air in and out. Respiration is at the cellular level. Okay. You'll need to know the airway structures, basically all the structures in the upper airway and the lower airway, and you need to know which structures are in each one. Okay. All right. Now, I have a bad habit of not advancing slides. I just look through the book and look through the book. All right, so this was the left lateral recumbent, Fowler, Trendelenburg positions. Here's your planes. skeletal system. Sorry, guys, I typically have a bad habit of advancing the slides. I just start talking. Okay, spinal column. So here's the sternum. You can see the body of it, the xiphoid process, and that upper area, up in this area, is called the manubrium. Seems like my video has gone off my screen, so I'm not sure what y'all, I'm sure y'all looking at me. Okay. Lower extremities, like I said, know the major structures in the lower extremities. And we're about to get to this, which is, it just shows you how vascular bones are, okay? You do have arteries in your bones, and we can lose a lot of blood from fracturing a bone. That's basically what this is showing you guys. Muscular system. Like I said, you're not going to have to identify these different structures on a slide, okay? So just know the terms. All right, so kind of in respiratory system right now. All right, I'm gonna stop right here, okay? All right, so like I said, no structures in the upper and lower airway. There's a term called aspiration in your book. That just means you've inhaled something in your lungs that's not supposed to be there. You can aspirate vomit, you can aspirate anything really, piece of meat, water, okay? It's just moving something into the lungs. When you talk about the lungs, you're going to hear the term visceral pleura and parietal pleura. The visceral pleura covers the outer surface of the lung. The parietal pleura covers the internal chest wall. So when you hear the word visceral, that just means it's covering an organ, or it's referring to an organ. Okay. Now, the diaphragm, okay, basically separates your chest cavity from your abdominal cavity. And the diaphragm is responsible for 60 to 70% of your respiratory effort. And I'm going to talk a little bit more about that in a minute. Anatomy of infants and children. A couple things just to note. In infants and children, the tongue is proportionally larger in a child. It doesn't mean that our tongue is smaller or theirs is larger. It just, theirs takes up more space in their mouth than an adult does. Okay. They have a much more narrow area in their cricoid cartilage. Okay, that's just below the thyroid cartilage, which is your Adam's apple. That's the most narrow portion of their airway. And their trachea is not fully formed. All that cartilage hasn't formed, and it's not as rigid as an adult. So you can actually kink their airway if you tilt their head too far back or too far forward. It gets into mechanics of ventilation, and it talks about inspiration and expiration. So when y'all hear inspire or expire, just means inhale or exhale. So when you inhale, that is an active process. Your diaphragm contracts, it flattens, it lowers down, intercostal muscles contract, and we cause negative pressure in the chest. Air is in greater pressure outside and it flows in. That is an active process, meaning it takes energy to do it. Exhalation, for the most part, is a passive process. We cut off that respiration, we relax, the weight of our chest pushes air out. Okay. Now we can make that an active process by blowing hard, blowing out, but mostly it's a passive process. So here's the adult versus child airway, and this is just some of the things that I talked about. The child has a smaller nose and mouth, tongue takes up more space, the trachea is more narrow, and so forth. So here you can see the diaphragm. just below the lungs. That's separating the chest from the abdomen. And then you can see the visceral and parietal pleural linings. Okay. All right, here's a picture of an alveoli. Let me get to that in the book. Okay. All right, so before I talk about that, I want to talk about, it talks about adequate and inadequate breathing. The average tidal volume in an adult is about 500 milliliters on every breath. Okay. When you get into the adequate, inadequate breathing portion of chapter 7, it starts talking about what normal ranges of respirations are. So the adult range is 8 to 24. That's a normal range, with the average between 12 and 20. Okay, so it gives you the wide range, but then the average is a little tighter. 8 to 24 is what we'd say in normal. 12 to 20 is average. Okay. So I want you to remember, children typically are about 15 to 30, and infants are 30 to 60. Okay, that's what average for those age groups. It breaks it down a little further in there, but just remember those. You may hear the term agonal respirations or agonal breathing. That's gasping, okay? We refer to it in the field sometimes as guppy breathing. It looks like a fish in a tank where they keep opening their mouth. It looks like they're breathing. They're actually not. So when you see a patient that has agonal respirations, really the muscles are contracting, but they're not pulling air in. It's inadequate, and that patient's about to stop breathing. So we need to step in and ventilate that patient at that point. Okay. All right, now we get into the circulatory system. You need to know blood flow through the heart, and you need to know it backwards, okay? So I think at this point, it talks about the basic anatomy of the heart, and it talks about all the parts of the heart and arteries and common areas where we feel for pulses, okay? So review all those. They're all bold terms, bullet points. And what I'm about to do is turn this laptop around and show y'all a simple way that I use to have you guys learn blood flow through the heart. Okay, give me a second. I'm gonna drop this down. I need to find where my video went. Hopefully I'm still videoing. I'm gonna stop the video for a second and then come back up. All right, at least now I can see what's going on. So when I turn this thing around. All right, give me a second here. Okay, got the whiteboard behind me. It's going to be a little bit at an angle, but that's about the best I can do right here. Okay, so typically what I do when I talk about blood flow through the heart, if you actually look at the heart, let me advance the, go to that area. Okay, right here. It looks a little confusing. I mean, we got all kind of action happening here. All right, once again, let me start. Okay, I don't know why it goes off my screen, so I don't know what y'all looking at. All right, so this is a picture of the heart, okay? I'm gonna draw a simple diagram and show blood flow through the body and the heart. Hopefully you can learn through this simple drawing how blood flows, and then come back and look at this, and then it make more sense, okay? So my drawing is not going to be to scale. A lot of stuff that I'm going to draw comes out the bottom of the heart, where actually normally it comes out the top, all these vessels. Okay, so hopefully it makes a little sense when I start drawing it. Okay. So think of the heart's 4 chambers. I'm going to draw some lungs off to the side. Okay. Now, in blue, I'm going to draw the deoxygenated side. Okay. So what I mean by that is deoxygenated blood's involved. So I'm going to start here. This vessel coming to the heart. I'm coming to the heart this way. Now, you think of this is your head. Okay. No, naturally that's not to scale. Y'all don't tease my drawing too much. Okay. All right. So deoxygenated blood is heading back to the heart. Right. This is the inferior vena cava, and this is the superior vena cava. Right? Now, they go into the right atrium. Okay, I'm just going to put RA because I don't want to write too much on here and get it all jumbled up. Okay, so we're in the right atrium. So remember, you're looking at the heart, but refer to it this way. The heart's in my chest, so you always refer to the patient's right and left. So if my heart's sitting in my chest like this, the right side, this is my right arm, right side of my heart's here, so the right side's here. Okay. All right. So blood comes into the right atrium. Then it's going to go through a little valve right here. Right? This is called the tricuspid valve. Right? Then we're in the right ventricle. The blood is heading through the ventricle. All right, and these little valves, what they do is they prevent blood from backflow. This is a much stronger chamber, so when it contracts, you don't want blood going that way. All right, so we're going to leave the right ventricle, and we're heading to the lungs. So we're going to head to the lungs this way. I'm going to draw one to the other lung just so we keep it involved. All right, so we're heading that way, and we're going to the lungs. All right, so inside the lung, you have your little alveoli, all right? The alveoli is the terminal part of the lung, right? This is where gas exchange is going to occur. Well, you have these little capillaries that line all over those alveoli, okay? And you can see that in your book, a picture of the alveoli. They had one on the screen a while ago. All right, so this deoxygenated blood has come down to the capillary level. And what we're getting rid of is CO2, or carbon dioxide, that is moving out of the bloodstream. We're getting rid of carbon dioxide. And what we're going to do is breathe that off. Okay, we're going to breathe that off. Now, at this point, oxygen, or O2, is moving into the capillary. And then we're going to head back to the heart. So we could draw a little out this way. Okay. So now we have all this freshly oxygenated blood, and we need to go back to the heart because the heart has to pump it to the body. So coming back out of here. So we come into this chamber over here. All right. So we're coming from this lung also. Just not drawing all that stuff on there. Arrows. Okay. We're heading here. Now we're in the left atrium. We're going to pass through another valve. This one is the bicuspid or mitral valve. Okay. Then we move through the little valve into the left ventricle. Now, the left ventricle, that's the strongest part of your heart, okay? This sucker has to pump blood to the whole body. This ventricle just pumps blood to the lungs, right? So we leave this ventricle in a big vessel called the aorta, okay? Now, that vessel is going to start getting smaller and smaller and branching out, okay? So it actually leaves the top of the heart, but that big vessel, things are going to start branching off of it, arteries, okay? Well, arteries, when they get smaller, they're called arterioles. And then real small arterioles eventually go down to capillaries, all right? So I'm going to draw some, say these are cells in your body, okay? So blood flow is heading to all the cells because we have all that oxygen. These cells need oxygen, okay? So right here, all that fresh oxygen is going to be offloaded into the cell for it to use. Now the cell has produced waste in the form of CO2, and they're moving that into the bloodstream, okay? Now, at some point, these two vessels, or capillaries, you have the high pressure side, which is your arterial side, your low pressure side, which is your venous side. Eventually, they kind of mesh together, okay? So now we're starting to return back to the heart. So these little capillaries turn into small veins called venules, then veins, and then all the veins eventually dump into the vena cava, okay? So now we're returning back to the heart with deoxygenated blood that the cells have used up, okay? So we have a lot of carbon dioxide in our bloodstream, back to the heart, to the lung, and we're going to make the circle back, okay? So for the purpose of this course, this is all y'all really need to know about blood flow and how it gets to the body. It's much more complicated, but for this course, this is what y'all need to know, okay? So I hope this little drawing kind of helped you. And then, like I said, once you know the structures that it goes through and how it goes around, then you can look at this actual picture of the heart and kind of figure out where things are going, okay? All right. Okay, so let me turn this thing back around. And we will continue on. All right, so in this slide, just know that there is a electrical side of the heart. Okay, we have a mechanical side and electrical side. Well, the electricity makes the heart contract, okay? So the sinoatrial node, or the SA node, that's your primary pacemaker. That's what sends the signal down the heart to make it contract. When it moves on to the atrioventricular node, or the AV node, it slows down a little bit because when the atria contract and then the ventricle contract, the chambers have to fill with blood again. So it has to delay that a little bit so they don't all just squeeze at the same time. Because the top of your heart beats and then the bottom, top, bottom, okay? And then it branches out to the in a little area called the bundle of His, and then your Purkinje fibers, all those little strands around the rest of the heart. All right, let me get through this. All right. So there's some stuff that y'all need to know before we continue on with that. One is the composition of blood. Basically, y'all need to know red blood cells, white blood cells, and platelets and what they do. Okay. Right. Then when we talk about blood pressure, and we talk about systolic and diastolic blood pressure, systolic is the top number, diastolic is the bottom number. Okay. Top number is always going to be higher than the bottom. Now, what is happening is in systole, or the systolic blood pressure, that's the pressure wave going through the artery when the heart contracts. Okay, that's that pressure wave. The diastolic blood pressure is when the heart is at rest or it's refilling. Okay, so that pressure wave's not passing through at that point. That's how much pressure is remaining in that vessel. Okay, so that's your systolic and diastolic blood pressures. Ready? Moving along. This one's just showing you the coronary arteries. So just know that the heart feeds itself first. All these little coronary arteries that are around the heart branch off at the base of the aorta. Okay. So when blood is ejected through that aorta, the heart's going to feed a supply of blood to itself in these coronary arteries. Here's composition of blood. So like I said, you need to know red blood cells, white blood cells, and platelets and what they're responsible for. And just know that plasma, the plasma part of the fluid part of your blood is about 55%. The formed elements are about 45%. This is showing you the arterial and venous side. So remember, the artery side is your high pressure side, your venous side is low pressure. And that's why we have these little valves so that blood cannot flow backwards, basically. On the high pressure side, it's just not possible. Okay, but we have these little valves in our venous system that prevent regurgitation of blood or from it going backwards. Okay. So let's talk about this slide. So this is talking about plasma onconic pressure and hydrostatic pressure. Okay. What y'all need to know about this is in that vessel, hydrostatic pressure pushes water out from intravascular to extravascular, inside to outside. There's a push. So if we increase hydrostatic pressure, or the pressure inside the vessel, fluid's going to leak out. Plasma onconic pressure, basically the draw within the vessel pulls water from the extravascular space into the intravascular space, or outside to inside. That's all y'all need to know about those two definitions. Hydrostatic pressure pushes from inside to out. Plasma onconic pulls from outside to inside. Okay. Now this is talking about preload and stroke volume. Okay. And what it's showing here is you can see the left ventricle in that top left is full of blood. Okay. So it's talking about normal volume of its pumping. Okay. If you reduce preload, the available blood for the ventricle to pump, naturally, we decrease the amount that's pumped out. Right. Just checking the book. This slide kind of jumps around. It's talking about stuff in chapter 8 already, but since it's here, I'm going to kind of talk about it. When you hear the term systemic vascular resistance, it's the ability of your vessels to constrict and dilate. Okay, constrict and dilate. When we want to increase blood pressure, we constrict blood vessels. Okay, when blood pressure drops, we can make the container bigger and to make pressure drop. So the best way I can explain it is think of a regular garden hose. So you have a regular 1-inch garden hose, all right? And let's say you have a certain amount of pressure behind it. I don't know, I'm making something up, 100 PSI, all right? And you can stand on one side of the room, point the hose, and hit the wall across the room because you got so much pressure coming out of that 1-inch hose. Now, if you don't mess with pressure, but all of a sudden we make that hose like a 5-inch hose, a lot bigger. Now we've made that container a lot bigger, and water is just going to trickle out of it now, okay? Because it's not generating enough pressure to make it through that big vessel. So that's what systemic vascular resistance is basically. If we want to increase pressure, we clamp down. We constrict that blood vessel. If blood vessels dilate, we typically see blood pressure fall, okay? All right, pulse pressure. The pulse pressure is just the difference between the systolic and diastolic blood pressure. Okay, so 120/80, we all heard that before, right? Okay, they say that's normal. Okay, so the pulse pressure is the difference between those two numbers. Okay. And this is a picture of just perfusion. Okay, this is kind of somewhat of what I drew on the board, how the left side is deoxygenated. We make our way through the heart to the lungs, pick up oxygenated blood, back to the heart, it pumps it to the body, to the cells, cells offload CO2, and we make the rise back, okay? All right, so let me cover some stuff in this chapter that we haven't talked about yet. So the nervous system, which y'all need to know is what's considered the central nervous system and peripheral nervous system. The central nervous system is made up of the brain and spinal cord, okay? The peripheral nervous system is everything extending off of that spinal cord. So if you have the brain and the spinal cord hanging from it, all right, that's central nervous system. From the spinal cord, you have all those little nerves coming off of it. That's your peripheral nervous system, okay? It talks about consciousness and unconsciousness and the reticular activating system. Just know that the reticular activating system is located in your brainstem, so at kind of the base of your skull there, okay? You have to have that working and one side of your brain functioning to have consciousness. If both sides aren't working, you will not have consciousness. If your brainstem's damaged or the reticular activating system's damaged, you won't have consciousness. The endocrine system, it talks about all the different glands. So just review, it just talks about a few of them, thyroid, parathyroid, adrenal, just know what they are and the definitions of them. Now it's getting into epinephrine and norepinephrine and talking about alpha and beta effects, okay? So when you're talking about alpha and beta, you have alpha 1, alpha 2, beta 1, and beta 2 effects on the heart, okay, or the body. Alpha 1 causes vessels to constrict. So if you have a specific medication that's an alpha 1 medication, it causes vasoconstriction. All your vessels clamp down to increase pressure, okay? Norepinephrine is one of those medications. Norepi is a primary alpha 1 medication where it constricts blood vessels. Epinephrine has all of these factors, alpha 1, alpha 2, beta 1, beta 2. Now, the good thing is we're not going to talk about alpha 2, okay? They're thought to regulate the release of alpha 1. They're still not too sure about alpha 2, so we can forget about alpha 2, okay? Let's talk beta 1, beta 2. Beta 1 effects affect the heart. So if I give you a beta 1 medication, heart rate increases, the electrical activity increases, and how your heart contracts, it contracts harder, okay? So it just speeds the heart up and makes it contract harder. That's a beta 1 effect. Beta 2 causes smooth muscle to dilate, and smooth muscle is located in your lungs. Okay, now it's located in other parts of your body, like your blood vessels and in your gut. We have smooth muscle, okay? But when we talk about beta 2 effects, usually we're talking about the dilation of your bronchioles in your lungs, all right? So when you're talking about beta 1 and beta 2, think of it this way. Beta 1 affects the heart, right? Well, beta 1, you have one heart. Beta 2, you have two lungs. So beta 2 affects the lungs. Now, beta 2s do have a little effect on the heart. Sometimes you see a little heart rate increase, okay? But it's a primary beta 2 response. Review the integumentary system and different layers of the skin, the epidermis, the dermis, the subcutaneous layers. Digestive system, it talks about the stomach, the pancreas, the liver, the spleen, gallbladder, and so forth. Just know what their functions are. As far as urinary system or renal system, just know that you have two kidneys, two ureters, so that's the little vessels coming from the kidneys, dumps into the bladder, and you have one urethra, okay? All right, now we're getting into medical terminology. Now, medical terminology is important, but there's a lot of information in this medical terminology, okay? I'm holding my book up. Hopefully y'all can see that. I may have to, I lost my screen, so I don't know what y'all looking at. Okay, so medical terminology, there's several pages of this. Please do not spend hours on end trying to memorize all this stuff. I would recommend that you guys gloss through it, kind of look at the major or the primary terms, okay? But please do not spend hours on end learning all this medical terminology. I would spend some time on it, kind of looking through it. Just don't spend a whole lot of time, okay? All right, sorry, I start and stop the video. That's the only way I can get it to pop up back on my screen. All right, now we're gonna kind of get into some chapter 8 stuff. Okay, we touched on some chapter 8 stuff a minute ago. All right. So when we talk about transport of gases, see where we're going. All right. So you can see oxygen, okay, 3% is dissolved in plasma, 97% is attached to hemoglobin. Don't really need to know these percentages. Just know that oxygen is attached to hemoglobin to be transported throughout the body, okay? Now, this is where things get all kind of complicated, all right? So when you talk about CO2, you can see 7% dissolved in plasma, 23% is attached to hemoglobin, 70% is converted to bicarbonate. We don't want you to focus too much on all this, okay, and learning all these percentages. Just know that this occurs, okay? Moving on. All right, so let's talk about aerobic versus anaerobic metabolism. Okay. So what this is showing you right here, it's just showing like a capillary and the little cells around it, and those communicating with each other are exchanging oxygen and carbon dioxide. So of course the red side, that's the oxygenated side, the high levels of oxygen, all right? You can see that they're offloaded into the cells, move in, cells get rid of CO2, and then we move to the low pressure side or the deoxygenated side. okay? And that's moving back towards the heart, okay? That's what we kind of talked about a while ago. All right. So when glucose moves across the cell membrane, all right, we need insulin to let it in. And we'll talk about that in a later chapter. But it's broken down into pyruvic acid, right? This process is called glycolysis. And it happens in the fluid part of that cell right there, okay? Now, when that happens, 2 moles of ATP is produced. Now, you don't need to know these moles of ATP, but I'm going to use them just to give you an example of what's happening, okay? So 2 moles of ATP are produced. And ATP is just an energy source. That's just an energy source that the cell needs to function, okay? Just think of it that way. Well, because there's glucose and there's oxygen, more specific oxygen, that reaction moves into the mitochondria of the cell, and more energy is produced, more ATP is produced. Another 34 moles of ATP is produced. So you have 2 moles when glycolysis occurs, but if we have oxygen available, 34 more are produced. So you get a big production of it, all right? That cell's functioning like it's supposed to. In anaerobic metabolism, glucose moves into the cell, glycolysis happens, those 2 moles of ATP still occur. But when we don't have oxygen available, that reaction doesn't move into the mitochondria. And after a while, pyruvic acid, pyruvic acid is turned into lactic acid, okay? Now, lactic acid is detrimental to the cell wall. Let's see if the next, yeah, okay. So when oxygen is not getting to the cell, and that lactic acid, that pyruvic acid's converted to lactic acid, the cell wall starts to break down. So what this is showing is little sodium and potassium pumps, okay? Potassium is the primary intracellular ion. We got a lot more potassium, we got a little sodium in the cell. Outside the cell, sodium is the primary extracellular ion. So we have a lot of sodium and a little potassium. Well, the sodium wants to flow into the cell, okay? Well, these pumps on the cell wall, that's what these kind of top things, if you could imagine that little kind of, I don't know if that purple cup looking thing, and that's the cell wall, that's those little yellow dots and stuff. So think of that, it's wedged into that little wall there. So they're constantly pushing in and out, okay? Moving sodium and potassium in and out. Now, because we have a lower concentration of sodium in the cell and we have a lot outside, those guys outside want to get in. Well, it needs to make an exchange, so the only way it can get the sodium in the cell out, it has to be pumped out against that higher gradient, okay? When that cell wall starts to fail because of that lactic acid and that little pump fails, all that extracellular sodium rushes into the cell, and then what happens is basically on the side, the slide on the side, the cell swells and then it ruptures and it dies, okay? So it's not coming back at that point. So that's why later on we learn about why it's so important to oxygenate our patients, is because we don't want cells to die. Too many cells die, then you have organs that start failing, or organs die, and then the organism dies, or your patient, okay? So that's why it's important to know about this process, and later on when we learn how to oxygenate and ventilate our patients, that's why it's so important. All right, so we kind of talked about the nervous system already, that in the slides a little earlier. Let me go through the book here. We're going to talk about airway, all right, and what's a patent airway. Yeah, these slides are all jumbled up, and I apologize. But here's when we were talking about alpha 1 and alpha 2, so it kind of gives you a visual. Remember, we can forget about alpha 2. Okay, alpha 1 constricts blood vessels, beta 1 increases heart rate, force, and automaticity, beta 2 dilates smooth muscle. All right, so mostly what I'm going to do now is just talk from the book. Okay. All right. When you hear the word patency or patency of an airway, my airway's patent. I'm talking, I'm breathing. Okay. Now, if I'm unable to do that for myself, we can do that for the patient. We can make them have a patent airway, right? And that's by opening their airway, maybe assisting them with ventilation. You need to know the definition of nasopharynx, oral pharynx. A lot of this is terminology, epiglottis, the larynx. This is moving down the airway, okay? You can hear the word carina. That's where the trachea bifurcates into the left and right main stem bronchus, or the passageway going to each lung, okay? The little area where it splits off is called the carina. All right, more terms y'all need to know. Compliance, airway resistance, pleural space. So what you have to think about is you have your lung, okay? So let's say this is outer wall of the lung, this is your chest wall, okay? So in between here is your pleural space, the little space in between. And that's some negative pressure in there, okay? Now, what it's designed to do is when you breathe and that lung inflates and deflates, that negative pressure prevents us from it hurting, okay, from doing that. If you think of it this way, if you ever took two panes of glass, okay, and put water in between them and mash them together, they're able to just slide, okay? So that is very similar to what the pleural space is, okay? Some other terms, minute ventilation. So remember I talked about normal tidal volumes, roughly about 500 milliliters for an adult. So all you do is you take that tidal volume, that 500, times the frequency of ventilation. So if I breathe 10 times a minute, it's 10 times 500. So it's 500 milliliters a minute, 5,000 milliliters a minute, okay? That's all minute ventilation is. Now they talk about alveolar ventilation. So all that is the air that we breathe in. The air that moves down to the alveoli is the only thing that exchanges gas. We have some wasted space in there, okay, or dead space. So if you think of the trachea, the bronchi, the bronchioles, okay, all those little branches in your lung, gas exchange doesn't happen. The air in there. So think of it this way. If I just breathed in, held my breath, all the air in my trachea and all those other vessels is not being used up. Only the air that's made it to the alveoli. So what you do is you subtract 150 milliliters from that 500 to account for the dead space. So now we're at 350. So alveolar ventilation is the 350 times how many times a minute the patient breathes. So it'd be 350 times 10 if I was breathing 10 times a minute. Okay, so I hope that makes sense to you guys. All right, moving on. Now we're getting into what's called chemoreceptors. Okay. So you have central chemoreceptors, and those are located basically in your brainstem, at the base of your brain. Okay. Those regulate how much CO2 or the CO2 levels in your bloodstream, and that's going to regulate how often you breathe. Okay. So if CO2 levels increase, then we're going to increase respiration because we have to blow that off. We're blowing CO2 off. That's the only way the body gets rid of it is to breathe it out. So as CO2 levels rise in the bloodstream, okay, those central chemoreceptors pick up on that and increase respiration. That is called hypercarbic drive, okay? Hypercarbic drive is normal. That is how we breathe, is what's called hypercarbic drive. Those little central chemoreceptors in our brainstem determine how much CO2 is there and regulate respirations based off of that, okay? And the increase of CO2, respirations go up so we can breathe it off. Now, you have people that have been exposed to high levels of carbon dioxide for a long period of time, like smokers. People that smoke a long time, sometimes what will happen is the central chemoreceptors just become numb to the amount of CO2 in the bloodstream. So they kind of stop working. Well, we have something called peripheral chemoreceptors, okay? They're located around the aortic arch around our heart, and they're also located in the carotid bodies in our neck. Well, those determine oxygen levels in the blood and regulate respirations based off of that. And that's called hypoxic drive, when your peripheral chemoreceptors have resorted to doing that, okay? That's called hypoxic drive, and that's not normal. Hypercarbic drive is what we call normal. So what happens is my O2 levels start to drop. The peripheral chemoreceptors that have taken over say, oh, we don't have enough oxygen, we need to increase respirations, pull more in, okay? But the weird thing that happens is if we flood those patients with high levels of oxygen, the body's like, we got all this oxygen, we don't need to breathe. So we can actually knock out their respiratory drive by flooding them with too much oxygen because those peripheral chemoreceptors are like, we got all the oxygen we need, we don't need to breathe. Now, in the rare occurrence that happens, and it is a rare thing that happens, all we need to do at that point is ventilate the patient if they stop breathing, okay? Now, in this chapter, it talks about lung receptors, irritant receptors, stretch receptors, J receptors. Just know they exist, okay? You don't really need to know the definitions of them, but I'll just kind of briefly talk about them. Irritant receptors make you cough, okay? Stretch receptors, basically when those alveoli stretch to a certain point, they send a signal to the brain saying, okay, it's enough, cut the signal off, all right? The J receptors are basically you have an alveoli with all these little blood vessels or capillaries surrounding it. So when that thing inflates and puts all that pressure on those little vessels, they get a lot of pressure put on them. They also send a signal saying, hey, that's enough, turn off respiration, okay? Or stop that inhalation. Now there's all these other stuff it talks about, respiratory control centers, the ventral respiratory group, dorsal respiratory group, the pontine respiratory center. Just know they exist, and they exist in the brainstem, okay? And they're all responsible for something, meaning either sending a signal to stop breathing or stop the respiration or increase it or something like that, okay? So just know they exist. It's nice to know, not need to know. So don't study those in depth, all right? You're going to hear the term ventilation perfusion ratio. All that means is in the lungs, nowhere do we have a perfect amount of oxygen or air and a perfect amount of circulation to grasp both, okay? So in your lung, okay, so we have a lung, let's say, all right? At the bottom of our lungs, we have a lot of circulation, okay? Have a lot of capillaries. But because air rises, right, we have more air at the top of the lungs. So we have more circulation at the bottom, and there's not enough air or oxygen to supply all the vessels, okay? In the top of the lung, we have a extra amount of air or oxygen and not as much vascular system, all right? So smaller vessels, so there's wasted air. There's some air out there that can't be captured because we don't have enough of the circulation. So just nowhere in that lung is it 50-50, okay, where they match. So that's all ventilation perfusion ratio means. All right, so some of this I've covered already. Composition of blood, hydrostatic and plasma onconic pressure. Okay, I've covered that already. You'll hear the term cardiac output. It's just the heart rate times stroke volume. Okay. And all stroke volume is the amount of blood that's filling up that left ventricle. Okay. Talked about preload and afterload. Well, I talked about preload. So remember, preload's the amount of blood that's filling that ventricle, that left ventricle up, right? Afterload is the resistance in the aorta that left ventricle has to pump against, okay? That's the term of afterload. And there's something called Frank-Starling's law or Starling's law. And what that means is the more you stretch the heart, the more blood we put into it, the harder the contraction's going to be, right? And the best way I can kind of explain that is like a rubber band. You have an average size rubber band, you put it on your finger, but you only pull it back about that far and let it go. It just kind of falls to the ground, okay? If you stretch it, you get a much more stronger impact, okay? So that's kind of the same thing with the heart. You put more pressure, you fill it up, you're going to get a bigger contraction, all right? That's what Frank-Starling laws talks about. Talked about systemic vascular resistance. Kind of talked about blood pressure. Baroreceptors, just know that they're stretch sensitive receptors located in the aortic arch and carotid sinuses, all right? And they detect changes in blood pressure. So once they determine that blood pressure's falling or increasing, adjustments are made, all right? Okay, and that's basically at the end of chapter 8. Okay, so I thought of something that I didn't see in the book, but I want to talk about when we talked about the diaphragm. You have something called the phrenic nerve. The phrenic nerve exits your cervical spine between C3 and C5. And that little nerve controls your diaphragm, okay? So it makes your diaphragm contract. And if that nerve is severed, so if somebody breaks their neck or their spinal column, their cord, I should say, that signal no longer gets there, the diaphragm is no longer going to work. And remember, the diaphragm is responsible for 60 to 70% of our respiratory effort. The rest comes from the muscles in between our ribs, intercostal muscles, and the muscles in our neck. But we can't maintain that if we lose our diaphragm. After a while, these patients they're going to end up on a ventilator. Okay, so that's the phrenic nerve that exits between C3 and C5 that controls your diaphragm. So I thought about that a minute ago. I hope this review helped you guys. And if you have any questions, just get with your local instructor. And good luck on your test.